Hello students, myself Dr. Soundarya, Assistant Professor from the Department of Pediatric and Preventive Dentistry, Vinayaka Mission Sankaracharya Dental College and Hospital. Today we are going to see is molar incisor hypomineralization. Moving on to the introduction, enamel is the hardest tissue in human body and contains highest percentage of minerals. Because of that, defect caused during enamel formation is permanent and it is non-repairable form as the enamel lacks the ability to remodel. So because of that, any developmental dental defect of enamel acts as a clinical challenges for each and every clinician that affects the as well as this type of dental defect that affects the quality of life, that is overall dental health and the treatment challenges. So molar incisor hypomineralization is one such defect which acts as a disturbances arising during any stages of enamel formation which exhibited as hypomineralization and hypoplastic defect. Definition: molar incisor hypomineralization is a clinical appearance of enamel hypomineralization of systemic origin affecting one or more permanent first molars as well as permanent incisors. This was the definition which was given by Verhegem in 2001. Also, Verhegem modified the definition in the year 2003, and according to that, it is defined as hypomineralization of systemic origin presented as well demarcated qualitative defects of enamel of 1 to 4 first permanent molars and frequently associated with similarly affected permanent incisors. These are the synonyms for the term MIH. Before it was coined as MIH, these are the terms that were used to mention the MIH. So the synonyms are hypomineralized permanent first molar, idiopathic enamel opacities, non-fluoride enamel opacities, internal enamel hypoplasia, non-endemic mottling of enamel, cheesy molar. So after that, in the year 2001, Verhegem finally coined the term molar incisor hypomineralization. Prevalence: the worldwide ranges of MIH from 3.6 to 40.2%. under which children are most commonly affected under the age of 10 years in the percentage of 15.1%. And the prevalent reports of India ranges from 2% to 27%. And female and male detection range from 0.81 to 1.04%. Moving on to the etiological factors. The etiological factors is based on genetic, environmental, medical and systemic factors. These are the main factors that are responsible for the molar incisor hypomineralization. It is a multifactorial origin. Environmental conditions, other factors like environmental condition, low socioeconomic status, perinatal complications, preterm baby, low birth weight, oxygen starvation and prolonged cyanosis at time of delivery, dioxins in breast milk and also vaccines, certain types of vaccines. Other nutritional deficiencies like calcium and phosphate, metabolic disorders, vitamin D deficiency, hypocalcemia, chronic childhood systemic diseases, antibiotics and hypocalcemia, thyroid disorders are the various etiological factors responsible for molar incisor hypomineralization. Moving on to the clinical presentation of MIH. The appearance of MIH is found to be white opaque to yellowish brown areas with well demarcated and distinct borders from the normal enamel, and also it shows discoloration ranging from creamy white yellow opacities to dark brown or brown opacities with distinct borders. And the discoloration of affected areas mainly due to the loss of optical character of the enamel and because of the loss of mineral content with the excess of protein and water content. And also one of the most common distinguishing feature of MIH is post-enamel breakdown, especially seen in the porous permanent first molars due to high masticative stress. If it is left untreated, it can also lead to severe hypersensitivity. If the post-enamel breakdown is left untreated, it can also result in hypersensitivity conditions. And because of this post-enamel breakdown, over a period of time, it can result in rapid caries progression due to its porous and friable enamel structure, and it finally destructs the crown structure, results in grossly destruction of the root structure, which can also progress to chronic inflammation of pulp, thus preventing its effectiveness of local anesthesia. And also because of its enamel breakdown and addition of the restoration material is also found to be poor in cases of MAH. So these are the overall clinical presentation. The patient will have hypersensitivity, difficult to anesthetize the particular involved tooth surface. Patient will have aesthetic problems, aesthetic concerns. Most of the, that is post enamel breakdown with restoration problems. So the features include enamel appears to be soft, porous or resembling discolored chalky white appearance of the enamel. The enamel will get easily chipped off under masticative forces, and the color of the hypomineralization varies from white to yellow or brown demarcated opacities. So the characteristic features of MAH that includes clear demarcation between the affected and sound enamel surface. Asymmetry of defects present mostly in the molars and incisors. And also another important thing about MAH is it does not involve second permanent molars and bicuspid, which are very rarely affected by these enamel defects. Next, an important feature about molar incisor hypomineralization is it can also affect the primary incisors. When it affects the primary incisors, that is primary molars, it is the terminology is called as hypomineralized second primary molar, that is HSPM. This, if it involves primary teeth, the condition mostly occurs in the primary second molar with the similar characteristics of molar incisor hypomineralization. Overall prevalence rate of MAH in primary molar is 1.6% to 20.4%, and the clinical appearance is similar to MAH with white, creamy, yellow or brown in color. If it is a brown dark opacities, that demarcated opacities are more prone to have post enamel eruption breakdown, that is post eruption breakdown, than white opacities. Children with HSPM, hypomineralized second primary molar defect, is 5 times more chances, that is children involving hypomineralized primary molar more prone to get chances of MAH in future. And so hypomineralized second primary molar acts as a valuable predictor of molar incisor hypomineralization. Moving on to the diagnostic criteria. Diagnostic criteria given by Veerhagam et al. In 2003. He gave 5 diagnostic criteria, like first one is demarcated opacities. Demarcated opacities are the most common features seen in MAH. It shows a clearly demarcated opacities at the occlusal and buccal surfaces of the crown. And second most common distinguishing feature is enamel disintegration, that is a post-eruptive enamel breakdown, which is most commonly seen in the porous enamel surface due to high masticatory stress or force. And restoration are found to be atypical. And if post-eruptive enamel breakdown is left untreated, it can also lead to tooth hypersensitivity ranging from a mild response to spontaneous hypersensitivity. And one of the most important thing is MAH mainly affects permanent first molar and incisors, which is rare in other dentition, other teeth of the oral cavity. In order to, for the examination, it can be performed well on a wet teeth compared to dry teeth. Moving on to the types of MAH. It is divided as mild, moderate and severe. Mild, it includes opacities in non-stress bearing areas, no caries is in affected enamel, no hypersensitivity, incisor involvement is usually mild if present. And in moderate cases, well demarcated opacities present on molars as well as in the incisors. And also post-eruptive enamel breakdown limited to 1 or 2 surfaces without cuspal involvement. And normal dental sensitivity seen. In severe cases, post-enamel eruptive breakdown is the most common distinguishing feature, with the history of dentinal hypersensitivity, and also if left untreated, they can also progress to crown destruction and chronic inflammation of pulp with aesthetic concerns. Severity scale according to APD. They gave 5 codes. Code 0 is no defect and code 1 is white or creamy demarcated opacities, which is considered as a mild, and code 2 is yellow or brown demarcated opacities, which is also considered as a mild form of MAH. And code 3 is subdivided into 3A, 3B and 3C. 3A is the opacities with enamel loss, which is considered as moderate form of MAH, and 3B and C. 3B is enamel and dentin loss. 3C is atypical large cavity extended to pulp and covering 1 or more tubercle. Code 4 with atypical restoration, and code 5 is extracted teeth. The codes from 3B to 5 these are the severe forms of MIH. Moving on to the differential diagnosis. MIH can be confused with these are the differential diagnosis. The first one is dental caries. But in dental caries, it will have previously intact primary dentition, but it slowly progresses to dental caries, and also sometimes white spot lesions also uncommon on incisors. And in fluorosis, diffuse enamel opacities which affect more than one teeth. Fluorosis is found to be in a generalized form compared to MIH. Enamel hypoplasia. In enamel hypoplasia, the edge of enamel is smooth, while in MIH, the post-eruptive loss of enamel renders the enamel edges sharper and more irregular. And amelogenesis imperfecta might be confused with MIH, but in amelogenesis imperfecta, the defect is found to be more symmetrical than MIH, and this is also a generalized defect which affects both sets of dentition. Hypomineralization defects, the etiological factors varies due to some local causes like trauma or infection of the primary predecessor compared to MIH. Risk identification, remineralization and preventive management. First focusing on the preventive management. For this, first we have to identify the risk. Children are more prone for MIH. We have to first identify the children with the help of some putative etiological factors in first 3 years of age, and also with the careful study of unerupted molars on radiograph. By this we can identify the risk factors. Following that, dietary assessment and necessary modification can be given during the post-permanent first molar eruption. And also, as a part of remineralization and desensitization, commencement of oral hygiene instruction, commencement of oral hygiene including a desensitizing toothpaste and remineralizing techniques can also be implemented. When the surface of permanent first molar is accessible, remineralization therapy can be commenced with the help of various remineralization techniques, which can be accomplished with the CPP, CPR resin infiltration technique, and use of topical fluoride. Like example, fluoride varnish can be applied onto the tooth surface to reduce its remineralizing effect and exercises to reduce its desensitizing effect and enhance its remineralizing property. And can also use Fisher sealant. In case of partially erupted permanent first molars, we can use glass ionomers cement based. Preventive management can be implemented. Treatment. According to William et al., 6 steps are needed to manage the molar incisal hypomineralization cases, which are as follows. First, we have to identify the risk, identify the patient at risk, and followed by that early diagnosis, early and prompt diagnosis should be done. Next, after diagnosing, initially start with the preventive management like desensitization and remineralization, preventing the occurrence of enamel caries, enamel breakdown and dental caries, and following that restoration of affected teeth or extraction if beyond possible repair. If in untreatable cases, restoration, extraction is the only option, and followed by that follow up at regular intervals and maintenance should be carried out. As a summary of treatment option, first risk identification, early diagnosis, next remineralization and desensitization, then prevention of caries and post eruption breakdown, finally follow up and maintenance. Next, moving on to the treatment of anterior teeth. There are various treatment options available for the anterior teeth, that is MIH involving incisors. That includes microabrasion, resin infiltration technique, H-bleach seal technique, external bleaching, and can also be carried out with veneering techniques or composite resin restorations and porcelain veneers. Then moving on to the treatment of posterior teeth, the treatment option that includes atraumatic restoration. We can advise desensitizing toothpaste, and we can also implement a fluoride varnish composite resin restoration if it is involving the post-eruptive enamel breakdown. Then we can go for intracoronal and extracoronal restorations, full coverage restorations, and prefabricated metal crowns we can also advise. Finally, if the teeth is found to be grossly destructed or if it is untreatable, then extraction is the last option. Clinical considerations for treatment. While doing treatment procedure, these are the considerations to be taken into account. First one is bonding. Since molar incisor hypomineralization will have less bonding capacity compared to other tooth structure. We can enhance the bonding with the help of 5% sodium chloride for 60 seconds after etching, which can enhance the bonding in enamel of MIH. And because of hypersensitivity and chronic inflammation of tooth structure, which can lack or which can reduce the effectiveness of LA. So for that we can use pre-medications prior to the use of LA, or we can use alternatives like Articaine in dilution with 1:4 lakh concentrations. And for while using sealants, bit and fisher sealants, or we can use GAC based sealants for porous enamel surfaces and resin based sealants with adhesives for intact hypomineralized molars. For anterior aesthetic restoration or anterior aesthetic treatment, microabrasion, while doing microabrasion we can use 18% hydrochloric or 37.5% phosphoric acid, and along with pumice, which yields acceptable results. In case of severe abnormalities, we can combine microabrasion with bleaching, which gives better results than single technique. Along with that, resin infiltration it is also a gold standard treatment option, which gives additional benefits, which can also enhances the remineralization effect and also reduces the demineralization and micro hardness. So these are the clinical considerations for doing a treatment for MIH patients. So thus I am concluding my topic that MIH is acts as a developmental dental defect which need to be properly diagnosed at appropriate time period, and stepwise treatment can thus limit the ill effects of molar incisor hypomineralization especially in pediatric patients. Thank you for listening.